So I guess the only way to make that bell stop is for me to start talking. Otherwise, it'll just keep going, giving me a headache. Okay, so this last session is shorter, so you'll be happy that we'll be finishing on time. This is another sort of a very simple question that often is difficult to answer, and that is whether a swollen nerve is truly edematous, or whether it's pseudo-edema for some reason or another. So I want to give you some tips about how to make the distinction, and then what sort of ancillary tests are going to be most effective for you to make the distinction when it's difficult. So I always start this talk by two quotes from America's most famous philosopher, Yogi Berra, who was a baseball player in the 60s and 70s, who used to say the most ridiculously sort of the malaprops, but they were really true. And here's two of them. You can observe a lot just by watching. And number two, if you don't know where you're going, you might end up there. So that's kind of the instruction for this talk. You want to know where you're going because you'll get there if you know where you're going. If you don't know where you're going, it's very hard to get there. Thanks to Yogi Berra. So this is my other slide that if you can't tell the difference between this and this, then you need another career, just like the other thing I told you earlier this morning. But it's not always easy to tell the difference between swollen nerves and whether there's edema there or not. And it's a common question, and it's a very important question to be able to answer. So let's go through how you do that. When I see a swollen nerve, and when I say swollen, it's a non-specific term, meaning that the margins are blurred and usually that it's elevated. That includes both edema and the causes of pseudo-edema of the nerve. So if I see that scenario, I'm asking myself three questions. One is it hyperemic? So is the disc pale swollen, or is it sort of red swollen in these scenarios? If it's pale swollen, it's unlikely to be true edema. Now, there are exceptions to that. Ischemic optic neuropathy in some scenarios is pale edema. Chronic papilledema is pale edema in some cases. But in the acute phase, where somebody's got a headache and they've got a swollen nerve, and you're trying to decide, is that real edema or is it drusen? Look for hyperemia, because it should be hyperemic in that scenario. The second is that, are there microvascular abnormalities? Is there something around that swollen nerve that suggests that the microcirculation on the surface of the nerve is not normal? In drusen and the other causes of pseudoedema, there are almost never any of these. So we'll look at that in more detail, but here's a little flame hemorrhage here. It makes it very unlikely that that's a drusen case. And the third is the margins are blurred, so all of these are blurred margins. So is the margin blurring due to nerve fiber layer edema, in which case the vessels run through that and they get obscured by the edema? Or is the margin blurring deeper than that, which is where drusen blur the margin, and the blood vessels are very clearly seen over the surface of it? So those are the three questions that I ask myself, and we'll go into some detail about what that looks like. So for pseudoedema, not true disc edema, what things are you looking at? We'll look in detail at drusen, but there are congenitally, quote, full optic nerves, hyperopia patients without hyperopia but having a little bit of a congenital anomaly of the nerve where it's elevated and there's no cup. That can look like edema, particularly if the nerve fiber layer around it has a little bit of extra tissue in it. This is a case that was sent to me as papilledema. This was actually a young boy who had had a viral syndrome and had nausea, vomiting, and headaches from the viral syndrome, and both of his nerves looked like this, and he was sent in as papilledema. What it really is a hypoplastic nerve with some extra glial tissue in the nerve fiber layer. So actually, there's some astrocytic proliferation in here, and parts of these vessels are obscured, but it's not really edema, and we'll see the difference between that and edema as we go through. And in some cases, you probably wouldn't miss this as acute papilledema, but chronic papilledema sometimes has gliotic proliferation around the nerve, some glial tissue that follows the vessels. In this case, this is a kind of a sheath of glial tissue. It's a congenital remnant on the surface. But you can see where you can't see the margins of the disc very well, and it might be mistaken for true edema. The last one is myelinated nerve fibers. Generally, you're not going to miss this, but to point out a couple of things about myelinated nerve fibers. Number one is it's in the nerve fiber layer, so it obscures the vessels, and you're seeing here's the disc and here's the disc, and there's this opacity in the nerve fiber layer. It has feathered edges because it's in the nerve fiber layer, and it obscures the vessels because it's in the nerve fiber layer, but it's really dense white. So this is true edema is not this dense, it's not this white, and so usually it's pretty easy to tell the difference, but if you're not experienced and you've never seen this before, you might mistake that for papilledema. Okay, so those are the kind of initial disclaimers that we'll talk about, but usually you're thinking about whether there are drusen within the optic nerve head, and you're mistaking that for true papilledema. So drusen usually do not have hyperemia, so it's a typical buried drusen case. The margins are blurred. It's kind of a pale swelling. There is a little bit of a nodular character to it, but not so obvious in this case. There are no microvascular abnormalities here, no flame hemorrhages, none of the others that I'm going to show you, surface capillary dilation, hemorrhages, and the vessels are very clearly seen as they come over the margin of the disc. So this case is clearly not true edema. You might also look for the anomalous vascular branching patterns that you'll often see with drusen or with other congenital anomalies of the disc. So not only drusen do this, but if you're looking at a swollen nerve, blurred margins again, and you see this weird vascular branching pattern, either this or I'll show you in a minute some others, and you're looking at the nerve and it's got blurred margins, but it's not hyperemic. You don't see flame hemorrhages. You see the vessels very clearly as they come over the edge here. Here, in this case, you have the clue that they're actually visible drusen here at this clump. But if you didn't have that and you just saw the rest of it, you'd be leaning toward disc drusen in this case. And here's some other things that you might look at for these vascular abnormalities. So just a lot of tangled branches on the surface of the nerve. This doesn't mean you can't have papilledema in there, but it's a marker that suggests, is there an anomaly there? Are there drusen there? You should be looking for it anyway. And again, the margins of this disc are quite blurred. And this way, instead of bifurcation of the vessels out to the periphery, there are trifurcations or four vessel branches or some weird kind of branching pattern. Should point you toward pseudoedema. When I said the margin blurring is deep, so this is what typical buried drusen margin blurring looks like. You actually see some visible drusen on the surface here, so you have the clue. But if you didn't have this, and you were just looking at this kind of a margin, it's not, we'll look at edema in a bit here. This is an example of true edema, and it's kind of a grayish white opacity, not dense like myelinated nerve fibers, but a grayish white, covering up the vessels here. Drusen is kind of yellow, and it's deeper, and you may see, in addition to that, you may see retinal pigment epithelial clumping, or in addition to that, yellowish blur of the margins here and here. You actually have a big clue here, is that you have a big drusen in the nerve fiber layer here, but assume you didn't have that, and you're just looking at the rest of it. That kind of visibility of the retinal pigment epithelium, you won't see that in edema because you can't see that deep. If the edema's there, it's obscured. You can't see down there to where the RPE is. So if you're looking at a blurred disc, you're seeing gray or black, that's probably going to be pseudoedema. So on the other hand, true edema, I ask myself these questions. Number one, are there symptoms of elevated intracranial pressure? Number two, are there other neurologic abnormalities? Is it acute or chronic? And what's the optic nerve function? These are the important things if you think there's true edema there. And let's look at what that looks like as compared to the other. So one of the things you may think about and read about is the physiologic cup being lost in papilledema. True, but it's kind of a later sign. It's gone in most cases of drusen right from the start. In early papilledema, the physiologic cup may be normal. So I don't look at that as a particularly good marker in early disc edema. So this is hyperemia. Red margin of the disc is blurred with the vessels obscured here. And this is to remind me, obscuration there, obscuration here and here. They don't have to be completely gone. It's just that you have to be able to see something in that nerve fiber layer that's obscuring it rather than the drusen that are deeper underneath. So there's a case of true edema. Here are the microvascular abnormalities that you're looking for in early disc edema. So a little bit of a flame hemorrhage here and here. Dilation of the surface capillary net, not so visible here, but you start to see it here with the hyperemia of the disc, and you can start to see the capillary net on the surface dilating up a bit, maybe a cotton wool patch here. And these are two examples of that dilation of the net. This stuff does not happen in drusen. So if you're looking at a swollen nerve and you're starting to see all of these vessels that are congested on the surface of the nerve, it's not drusen. It's true edema. It's microvascular edema. It might be a central retinal vein occlusion. It might be something else, but that's not pseudoedema doing that. Again, the nerve fiber layer opacity is grayish-white rather than deep and yellow. It has kind of a fluffy appearance and feathered margins, just like myelinated nerve fibers, so the edges of it have a little bit of feathering appearance. One of the things that I look at, it's very hard to pick up in pictures, but one of the things I look at to know that I'm looking at edema rather than something else is I look really carefully at this area that's the nerve fiber layer edema. And if it looks like it's sort of Swiss cheese, or I put here moth-eaten appearance, but there's this gray nerve fiber layer thickening, and then there are little holes in it, little round, not opacities, but openings in that. If you can see that, there's a little bit of it here. It's very hard to pick up on pictures, but I look really carefully for that character. There's a little bit of it here, where it's just patchy. And if you can see that, that's almost always edema as well. Pseudoedema does not do that either. Now, later on, these are the ones you won't miss, but here are more extensive of microvascular abnormalities, more hemorrhages, more micro infarcts, cotton wool patches here, some exudate, some hard exudate as well in there. This is what happens as things get worse in papilledema, but this is not hard to distinguish. It's just what happens later. The confusing part is when you see a patient who's got chronic papilledema, so not the acute phase, but as it's been there for a while, the hyperemia starts to go away, so the disc starts to look more normal or paler, and you start to develop gliotic tissue, which the gliosis spreads along the vessels and produces some sheathing. And with atrophy, also, you develop this nerve fiber layer dropout that I mentioned earlier today. So even though the disc is not atrophic looking here, it's got big areas of nerve fiber layer dropout here and here. You can see some thinning of the nerve fiber layer here as well. So it's a little harder to distinguish from drusen, but it still has these characteristic features. This is, again, this sort of moth-eaten appearance, little dark holes within that area of gray-white opacity. Harder to test. So this is a disc, and if you were following that disc for pseudotumor cerebri syndrome, that you're worried about this one, right? This is a disc that's developing field loss. If this is on maximum medical therapy, this is a pseudotumor case that's going to surgery because they're losing vision. Yes.
What does it indicate as dark holes?
It's so hard to explain this, but it's areas where the edema is sort of resolved in little patches, and so it's clearer to see through as opposed to the rest of it that's partially opaque. And that kind of appearance doesn't happen in pseudoedema. Chronic disc edema also can develop so-called optociliary shunt vessels, or more correctly termed retinochoroidal collaterals. They're not actually shunts, they're just dilated previously existing vessels that, because of the blockage of outflow from the central retinal vein, they develop this collateral which comes off of this and dives into the choroid and has an alternate drainage route. But optociliary shunt vessels for chronic papilledema, not only we think of these for optic nerve tumors, but chronic papilledema as well can look like that. And it doesn't happen in drusen for the most part. Here's an example. I showed you this one yesterday of a no light perception pseudotumor case. This is the ultimate gliotic disc from chronic papilledema. All of this stuff is not edema anymore. This is all gliotic proliferation from the chronic edema with sheathing coming out along these vessels. Very nice example of that in an unfortunate patient. You don't ever want to see this. And the last thing about true edema is that some cases of true edema from the exudation out of the vessels produce these little lipid particles that look like drusen. So it's a little bit of a confusion, except that they're more on the surface of the nerve and not sort of deep within the nerve. These are drusen here. They're smaller. They tend to clump around the periphery of the disc margin instead of all throughout the disc itself. And they go away as the disc edema goes away. These are just lipid exudates. But if you see that as a first scenario before it's gone away, it's a little bit confusing. You might mistake that for drusen, although they look different. All right, so here it is. Here's the quiz. You thought the quiz was going to be later today. Here's the quiz. Which of these is pseudoedema, and which of them is true edema? Is anybody going to be courageous enough to say something here? The left one is true edema. Okay. And here's some dissenters in the background. We'll get to it in a second. So you think this one is pseudo-edema? That's correct?
Yeah. Eliminated fibers.
Say that again?
Eliminated fibers.
Okay, so you think this is not edema, but it's myelinated nerve fibers.
Yes.
Okay, so this one, and this one looks like drusen, someone said? So what about, one of the things I didn't mention was that if you've got, these are myelinated nerve fibers, of course. If you have myelinated nerve fibers, sometimes the disc looks particularly hyperemic just by comparison, because this is so white, this looks more red, and this is a dark picture, of course, it's kind of confusing there. This looks more red, so you might be confused by that. Anything else you see on the disc surface here?
The microvascular.
Yeah, there's a lot of microvascular dilation on this disc surface. So this is both. This is both.
Myelinated disc can have.
Not that I would ever trick you, but this is both. So what about this? So is this hyperemic? A little bit. Do you see obscuration of the vessels? Not so much, but as I said earlier, it doesn't have to be completely obscured. Maybe there's a little bit here and here. Not a lot. Any microvascular changes otherwise? No. If you look carefully at this disc, even though it's hyperemic, there are some drusen here. There are possibly drusen in here. And the vascular branching pattern is abnormal. So you are thinking about this as a drusen case, which it is, and it also has true edema. So both of them have both. So just to show you how confusing this can be. But this one does, if you look at this, initially this looked more like drusen, but it did have some edema. This looks like definite myelinated nerve fibers, but if you look carefully, this is a guy who had a brain tumor in addition. So that's the clinical part. So what about the ancillary testing? Which test is best for you to do to try and confirm that you have drusen in there? B-scan ultrasonography, very simple clinical test in the office. If you get a B scan and you turn the sensitivity down and you still have a hyper-reflective spot there from calcification, you can confirm that there's drusen in that disc. Autofluorescence, either by an old technique or by the new technique, looking for the drusen which autofluoresce. I'll talk about that. Fluorescein angiography, looking at the difference between late staining of drusen versus late leakage of fluorescein. Or what about OCT? We haven't talked much about OCT of the disc. This is OCT of drusen. This is OCT of edema, which is going to be better than. So here's a case. Let me show you an example case here and see what you think about this. 36-year-old obese woman, has got headaches, has migraines, however, so you're not sure what to make of that headache. Every neuro-ophthalmology patient has migraines, just so you know. She has no true transient visual obscuration, but she has some visual blurring. She does not have tinnitus. She's using over-the-counter medications for her headaches. She's got good acuity. Pupils are equal. Maybe they're sluggish. The clinician wasn't sure. Eye movements are normal. Visual fields show these inferior arcuate defects on exam. And there's her fundus. Blurred margins. As you can see, there are no spontaneous venous pulsations. Nobody's going to answer that. Okay. Nobody's going to respond there. Of course there aren't any spontaneous. Okay. So the margins are blurred. You maybe see a little bit of obscuration of the vessels here. They're not hyperemic. This is kind of a non-specific picture to me, really. This has a few features going either way. So that's what you have. So what could you do? If you were really worried about a tumor and you were looking at this scenario, one thing you could do, although we rarely do this, but if you did CT scan through the orbits and there are drusen there, they're very easy, and they're calcified. They're very easy to pick up. It amplifies the signal. They're not really this big, but they show up with this big, bright signal at the optic nerve head. So that test might tell you that there are drusen in the nerve. It doesn't tell you that there's not edema on top of it. It just tells you there's drusen. Similarly, for ultrasound. So if the drusen are not calcified, they're not really picked up. You'll see an elevated optic disc here and here. But as you turn this down, if it's calcified, it will stay hyper-reflective here. If it's not calcified, it will go away, just like if you didn't have any drusen there. So it's a roughly 50% calcification and hit rate for this. So about 50% of the time, if you have drusen there, you're going to find them. 50% of the time, you're not going to find them. And again, this test alone doesn't tell you whether you've got edema. It just tells you whether there's drusen there. So I don't use this test very much. Most clinicians like this test because it's very easy, non-invasive, it's very fast, it's in the office. But it doesn't tell me what I need to know, basically. Similarly for autofluorescence, this is a test that we used to do when we were doing fluorescein angiography. So get the patient in place, put the filters in place before you inject. Look at the back of the eye and see whether this disc is lighting up with autofluorescence. This is a new technique for retinal autofluorescence that will also show you optic disc hyperfluorescence with drusen. This is even less useful for me. Most of the time, this is not as highly positive, so the hit rate is about 20%. If you have drusen, you'll see autofluorescence. And almost all of them are drusen that are on the surface, because you're looking at the surface to find it. And you don't need this for that. You can see the drusen already in most of these cases. So I don't use this. The third test is fluorescein angiography. And the thing that's been described most often about fluorescein angiography is looking at the late frame of the disc. So drusen look like this, where it's hyperfluorescent. The margins are slightly blurred, but it's mostly staining of the disc. So there are nodular uptake of stain more here and here than the rest of it, but the whole disc is a bit hyperfluorescent compared with edema, in which there's hyperfluorescence, and the hyperfluorescence extends out into the retina, leakage versus staining. I don't know about your retinal fluorescein angiography departments, but ours commonly misread this and call this leakage from the disc, whereas this is staining. So the late phases, you can often tell the difference. Not always, but you can often tell the difference. what I do also, I look at the whole fluorescein sequence, and I use fluorescein angiography quite a bit for the cases that I can't confirm, because there's a difference here. Again, drusen versus edema, the late phase, which I showed you, this is another case of late leakage. This is the same drusen case. But the early phases also are quite different. So in this case of drusen, there's an early blockage here, and sort of gradual uptake in the rest of the nerve, and then it looks like this. In edema, it fills very early, and the whole thing is hyperfluorescent and leaking early. So not only the late phase, but the early phase can help you distinguish between the two. Buried drusen have a specific look also, and this is something that's not as well sort of established in the literature, but this is a buried drusen case that is a confusing looking fundus. You could make an argument for either way about this. But when you look at the fluorescein angiography of the area of buried drusen around here, this is the hyperfluorescent staining, and the rest of the nerve is not hyperfluorescent at all. So this is buried drusen that are at the edge of the nerve. And for me, this is a very specific sign. We published this a few years ago looking at that. So in trouble cases, I always look at this. And in this particular case, that's what it was. So this is this same case, and it looks early on, no early leakage, gradual uptake of stain, but not of the disc itself so much, but of this peripapillary region where the drusen are buried. Underneath the vessels, not diffusing out into the retina, but localized in this region. So that's a typical late fluorescein picture for drusen. So what about OCT? You know, OCT is so great for so many things. It's non-invasive, it's very quick. So now we start thinking about whether you can make this distinction using OCT so you don't have to inject fluorescein. Kids are very hard to get fluorescein angiography on, whereas OCT is easy. So do you use it? This was the original sort of look at this. It's only 10 years old, a little less than 10 years old, from Len Johnson and Associates back in 2009, looking at old. These things look so rough now compared to what we can do. This is time domain OCT from that time frame. Swollen nerve. And the idea behind his initial paper was you look at the underlying pattern and see whether it looks kind of lumpy, like there are drusen in there, versus the underlying pattern that's smooth and maybe has a V shape from the hyporeflective fluid underneath there. This is what was published, and in cases where there are obvious drusen and obvious edema, you could see this. But in the cases where you really need it, the distinction was not very clear, and the resolution was not very clear, and it never really caught on with this level of OCT for making the distinction. Also, more recently, there have been a bunch of papers looking at nerve fiber layer thickness maps to distinguish between drusen and edema. And of course, in the acute phase, edema is thickened. Some drusen cases have thickened nerve fiber layer. Some drusen cases over time develop atrophy, and they have thin nerve fiber layer. And it just did not turn out to be a very good distinction between drusen and true edema. So we don't use this so much. This is what we're starting to get now. So what's so-called enhanced depth imaging for spectral domain OCT. Great resolution, and this is not even the best scenario. This is kind of an older picture. And in many cases, you can identify drusen within the nerve. So if you get this kind of a cut and you see a hyporeflective space surrounded by a hyperreflective rim that's a little bit irregular, you can confirm that those are clumps of drusen within the optic disc. And more recently, we've been using swept source and gotten some pictures with swept source OCT, which is just much faster, so you get many more images in the same amount of time, and the resolution gets better. It's even better than this. But this is the same principle that you can look at that and see that there are drusen in the nerve. That said, it's very confusing. Now, this is from a recent paper in Ophthalmology 2017, describing 3 appearances of optic disc drusen within the disc. So this appearance, which is the same thing I just showed you, I would say this is very clear. If you see this in the disc, you know there are drusen in there. This is less clear, and it probably does represent little bits of calcium within the nerve and little bits of hyperreflectivity, but it's not 100% specific. This was reported at the edge of the nerve, a sort of isodense, not hypodense like this, but isodense lump at the margin of the nerve, mildly hyperreflective. This was reported in this paper as drusen, but it's not accurate. I would disregard this. This is seen in edema as well. Anything in which the disc margins are elevated, probably due to folding of the tissues, produce this hyperreflective margin. It looks like a mass, but it's really probably folding of the tissues. So there are 3 reported cases. These 2 I would take as drusen. It's also confusing looking at the disc, trying to identify drusen, because they can look like vessels. What happened there? I touched the table and it went crazy. What do I have to push in here? Oh, this. There we go. They're disconnected. Maybe it was this. This came up that. Yeah. Okay. So it can look like, vessels can look like drusen. So vessels, for the most part, if you look at them, I don't think I have any good retinal pictures here, but most of the time in the retina they look like this. They're hyper-reflective, they're vertically oriented, oval with a little hyper-reflective band down the middle of it. But depending on the flow pattern, they can also be hypo-reflective in the center. And you see these within the disc, and it's a little bit unclear as to whether this, which I would say is probably drusen, because of the margin of it being this white irregular band. This is probably a vessel for sure. This one I'm not sure. This one sort of has this smoother band around the edge. But you can see where it's not clear whether those are vessels or not within the disc surface. The real problem with distinguishing drusen from optic nerve edema on OCT is that there's not a good endpoint for edema. There's a good endpoint if you catch these drusen in there. The endpoint for edema is vaguely identified. You have this hyporeflective space here, but there's a hyporeflective space here too. So you're not sure if this is edema or drusen. This does happen to be edema in this case. And here's that band at the margin of the disc that was said to be just from drusen, but this is actually edema, probably folding of that tissue at the edge. So that's the main problem. OCT, many of them are sort of, if you don't have clear drusen in there and you just got elevation and a hyporeflective space, it can look exactly the same. Whereas fluorescein angiography looks very different. There's a clear endpoint for fluorescein angiography with edema versus staining. So to me, still, if I have a question about this, I will do fluorescein angiography. OCT is going to get better. It does tell you for sure there are drusen. It just doesn't tell you for sure about the edema, but I think that the next generation of these is going to be the answer to this. You'll be able to distinguish little patches of edema within there in a hyperreflective space in a different shape than you see with drusen. So I think that's going to be the answer eventually. So finally, how do I manage pseudoedema? If I think I've got a case and I'm not clear whether it's drusen or not, I think it's probably drusen, but I'm not clear, and they have some symptoms, like that young boy I said was sent in to me with headaches, nausea, and vomiting that turned out to be a viral syndrome, I'll treat them as if they got papilledema. I'll send them for imaging and I'll get a lumbar puncture, because even though you got drusen, you still might have a brain tumor. If it's identified that they don't have a tumor and they've got drusen, we do what's called photoperimetric therapy. That means take pictures and do perimetry, and that's it. And watch for the occasional complication. Occasionally they've got subretinal neovascularization, even occasionally vascular compromise from the drusen. True edema, this is my last slide to remind you that if you are the first person to see a case and you think it's papilledema, you don't send them out with a prescription to get a scan. Now those people need to go immediately for imaging, because in ophthalmology, most of the people we see that have this are pseudotumor cases. So we get kind of casual about it, and we'll scan you and make sure, and eventually we'll get a lumbar puncture. No, that might be a brain tumor that's going to kill them. So they need to go to the emergency department or go to the neurosurgeon that you know or to a neurologist and get imaged immediately. So that's the most important thing about true papilledema. I'll stop there and ask any questions. I got us back on time, didn't I?
You sure did.
All right, thank you. And my last talk, I'd really like to thank the organizers here for inviting me here. It's really fun to have an engaged audience like this and talk about these things that we do every day. So thanks for staying awake.
Thank you, Tony. And Laura, could you join your husband? To quote your current president, our goal, rather than my goal, with this course, has been to make neuro-ophthalmology great again.
Did you have to quote?
He has said a lot about Malmö. Yeah, before. He was telling the world how many people got shot here.
Oh.
And you have been staying at Malmö live.
Thank goodness.
So we were thinking, you could go back and you say we stayed alive in Malmö.
We survived. Thank you. This is going to be really small.
So, I survived Malmö.
Thank you.
The remainder of the trip in Sweden. I know you're going to Stockholm.
Excellent. You can have this back.
Okay, thank you so much.
Thank you.